Good evening, ladies and gentlemen, and welcome to the last of our Cleveland Clinic webinar series tonight covering the topic of heart failure. I would like to start by thanking two specific people who contributed significantly to the success of this series. Professor Tuju, our Chief Academic Officer and the Chairman of the Heart and Vascular Institute, for his visionary planning of these webinars, and special thanks to Dr. Mahmoud Traina, the Director of our Heart and Vascular Education and the Section Head for Interventional Cardiology, for the tremendous amount of work he put to bring these webinar series to life. I would like to welcome my co-moderator for the session tonight, Professor Randy Starling from Cleveland Clinic in Ohio. Of course, Professor host of during these presentations, we will take 2 sessions for questions and answers after each 3 presentations. We'll have an excellent discussion covering the entire spectrum of heart failure, from chronic heart failure all the way to advanced heart failure and even novel therapies. Let me start by welcoming again Professor Starling and hand over the microphone to him to introduce our first speaker.
Thank you very much, Ferris, for the introduction and the opportunity to participate in this really wonderful series that Professor Tuju and other of your colleagues have had the vision to put together. What's really exciting is that we are covering the globe with Cleveland Clinic speakers tonight. Very exciting. So I'm going to introduce the first speaker, who is Dr. Ghalib from Cleveland Clinic, Abu Dhabi. Dr. Ghalib did his medical school training in Baltimore at Johns Hopkins and subsequent training at University of Michigan and at UCLA. UCLA being one of, if not the largest heart transplant program in the country. So Dr. Ghalib, we look forward to your presentation. Thank you.
Hello and welcome to the Heart and Vascular Institute webinar series. Today we'll be starting off with the heart failure section. My name is Hussam Ghalib. I'm one of the heart failure and transplant cardiologists at Cleveland Clinic, Abu Dhabi. And today we'll be talking about heart failure with reduced ejection fraction, medical therapy, more classes, but what sequence? I have no financial disclosures. This will be the brief outline of the talk. So heart failure with reduced ejection fraction is defined as a clinical diagnosis of heart failure with congestion, as well as reduced ejection fraction less than 40%. And importantly, it is a condition with the rising prevalence both globally and regionally. It's associated with significant morbidity and mortality, and they're associated with significant healthcare costs, and that's why it's important. So the treatment goals of heart failure with reduced ejection fraction are mainly mortality benefits and morbidity benefits. So you want less death for the patients, whether that be from sudden cardiac death or cardiogenic shock, as well as less hospitalizations and improved quality of life and less severe symptoms. So those are the main goals of therapy. And here's just a quick chronological order of all the randomized controlled trials that resulted in the evidence-based guideline-directed medical therapy, as you see here, starting with the angiotensin converter enzyme inhibitors in the late 80s and early 90s, moving on to hydralazine and nitrates, then to beta blockers, then to mineralocorticoid receptor antagonists, or aldosterone antagonists, as they're better known. Moving on to angiotensin receptor blockers, then ivabradine, and then the angiotensin receptor neprilysin inhibitors, which have garnered a lot of attention, appropriately so. And then lately, the sodium glucose cotransporter receptor inhibitors, such as the dapagliflozin and empagliflozin, canagliflozin, and then lately vericiguat, which is a soluble guanylate cyclase stimulator. This is an important slide showing really what are the starting doses and the target doses of all these different classes of medications. And I refer you to this very important reference by Dr. Clyde Yancey, showing that you really want to end up at the target doses of all these medications if tolerated. So just because somebody is on one of these medications is not sufficient. You really do want to hit the target dose that was achieved in the clinical trials showing the benefit of these medications. Importantly, what is effective therapy? So in all these different randomized clinical trials, all these classes of agents have been shown to have a reduction in mortality. So ACE inhibitors and or ARBs have a 20% reduction in mortality when compared to placebo. Beta blockers at 31% reduction in mortality. Aldosterone antagonists at 25% reduction in mortality. And then lately with the angiotensin receptor and neprilysin inhibitors, this was the pivotal Paradigm HF trial in which patients were compared to a placebo, compared to a group that were not taking a placebo, but were rather taking standard medical therapy, 16% reduction in mortality. And then for the SGLT2 receptors inhibitors, a 13% reduction in mortality, and we'll get over this in a little bit. So as you can see, starting patients on these medications really helps them live longer and have less death. What about when you use them in combination? So if you use a combination of ARNI plus a beta blocker plus an aldosterone antagonist, you can reduce mortality by up to 63% compared to placebo. And I refer you to this very neat meta-analysis showing this. For patients who are on ACE inhibitors or ARBs plus beta blockers and aldosterone antagonists, the reduction in mortality is also sufficiently high enough at 56%. So it's important to make sure that the patients are on all different agents that are part of our armamentarium in heart failure. But what's the sequence? So do you start with a beta blocker or with an ACE inhibitor? And the real answer is either. You can start with either a beta blocker or an ACE inhibitor, and there was the pivotal trial called the CIBIS-3 trial that showed that. However, we tend to use ACE inhibitors or ARBs earlier than beta blockers if the patients are congested, mainly because the patients are still decompensated and require the positive chronotropic and inotropic effects in order to get over the decongestion. And if the patient is euvolemic and has an adequate resting heart rate and no bradycardia, then we use beta blockers. The next question that usually comes up is, do you titrate the ACE inhibitor and beta blocker first, or do you add an aldosterone antagonist to them and then start titrating higher? And the real answer is to really add the aldosterone antagonist early on. So before you even achieve target doses of ACE inhibitors or ARBs, as long as the patient doesn't have any significant renal dysfunction or hyperkalemia. And it's been shown more and more recently that these aldosterone antagonists are really underutilized as part of the heart failure therapy. So in clinical trials, only about 63% of the clinical trials in the last few years had patients on MRAs, and in national registries, specifically coming out of Scandinavia, only about 40%. So terribly underutilized, with an association in terms of worse outcomes. Now, do you switch an ACE inhibitor or an ARB to an ARNI? And the answer is that's actually recommended, but you just have to be very careful about the blood pressure and make sure not to make that change during the acute heart failure decompensation. Importantly, if you're switching from an ACE inhibitor to an ARNI, there needs to be a washout period about 36 hours to avoid any significant side effects. Should you start straight away with an ARNI and just avoid even starting with an ACE inhibitor or an ARB? And the answer for that is sure, that's actually recommended as part of the 2021 expert consensus pathway that I have referenced at the bottom here. And once again, just make sure the patient is not hypotensive, does not have renal dysfunction or significant hyperkalemia. And make sure there's no absolute contraindications. So severe hepatic dysfunction, angioedema to ACE inhibitors or ARBs are the main things to keep an eye out for. But as of 2021, it's now recommended to start straight away with an ARNI as opposed to starting with an ACE inhibitor or ARB and then switching. However, you have to keep in mind that that's not at the expense of an MRA. So the Paradigm-HF trial included patients who were receiving MRAs as part of their standard therapy. So it's really important to start the MRA first if you're gonna start a patient on an ARNI initially. What about SGLT2 receptor inhibitors or ivabradine or these new agents such as vericiguat? And the important thing to keep in mind is none of these agents were associated with a reduction in all-cause mortality. So you're really talking about a morbidity reduction here, which is not something minor, but it's just to keep in mind. And these agents are really to be used in select populations. So I'll just briefly note this here that the pivotal trials in dapagliflozin and empagliflozin had shown no reduction in all-cause mortality, albeit just a reduction in rehospitalization. And these were sicker patients, so they all had to be hospitalized or had elevated BNPs. So this isn't your stable outpatient. When analyzing a meta-analysis that included just about 40% of the patients in the two trials, there was a reduction in all-cause mortality. However, that was not the takeaway home message of the RCTs. So, so we do use dapagliflozin and empagliflozin if a patient has had recurrent hospitalizations, has an elevated BNP, is already on ARNI, beta blockers, and mineralocorticoid receptor antagonists, and has no contraindications. Ivabradine, as studied in the SHIFT trial, has resulted in a reduction in rehospitalization, but these are high-risk patients, so also prior hospitalization. And importantly, these have to be patients who are on optimal dose of beta blocker, because when the SHIFT trial was reanalyzed, those patients who are on optimal beta blocker dose did not reap this benefit. And the treatment effect was similar to placebo. And recently, vericiguat from the paper in New England Journal had shown a reduction in rehospitalizations in patients with worsening heart failure. So these are patients with recurrent rehospitalizations, NYHA class 3 to 4 symptoms. And then this agent got approved just in January 2021. It's not available in our market, but it's available in the United States. And these are the references for you to peruse. So how often are you supposed to titrate these medications and how quickly? And the answer is not very quickly. So every 2 weeks, make sure to check these patients frequently, check their blood pressure, make sure the renal dysfunction doesn't get out of hand, check their electrolytes. And for that, you can have the help of heart failure pharmacists, which is what we utilize in our program. And do it slowly over about a period of 3 to 6 months, mainly to give the patients a time to get used to these medications and to avoid any significant side effects. So how do we go about the therapy here at the Cleveland Clinic of Abu Dhabi? So we start with the beta blocker, titrate that to dose, because that is a dose-related mortality and morbidity benefit. Then we add the ACE inhibitors or IRBs, after which we add the MRA. And then we switch the ACE inhibitor or ARNI to the ACE inhibitor or ARB to an ARNI, and then titrate these agents up to dose. Importantly, if the blood pressure is a limiting factor, make sure to prioritize the beta blocker first over the RAS blockade. And that's an important thing to keep in mind, because the pivotal trials had shown that the beta blocker dose really has a dose-dependent mortality reduction. So the higher you are in the dose of the beta blocker, the more you're able to prevent death in these patients. In very rare cases, we end up using ivabradine for patients who are on maximal beta blockers or in sinus rhythm and yet have a resting heart rate above 70. And then in patients who've had previous hospitalizations, we are now starting to use SGLT2 inhibitors more and more. We're looking forward to the approval of the vericiguat in our market, but that's also another part of our armamentarium for patients who've had recurrent hospitalizations, higher NYHA functional class and such. I refer you to these very important documents from which I obtained most of the information today, the 2017 focus update and the 2021 update to the consensus decision pathway, which is a very wonderful document that can walk you through how to initiate and maintain patients on heart failure therapy. And with that, I thank you and open it up for questions.
Dr. Galib, thank you very much for that presentation. I would like to remind everyone that is joining us today that you have the opportunity to submit questions online through the Q&A opportunity. So we will do our best to address most of your questions in the upcoming discussion period. It is my pleasure next to move on to the next topic. We covered heart failure with reduced ejection fraction, now heart failure with preserved ejection fraction. And Dr. Sean Bhattacharya, who is a heart failure transplant cardiologist at Cleveland Clinic in Cleveland, Ohio, will lead us through this topic. Sean.
Hello, I'm Sanjeev Bhattacharya, and I'm here to talk about HFpEF, particularly strategies that reduce hospitalizations. I am one of the heart failure doctors at Cleveland and excited to be a part of this seminar. So I have no disclosures. And our objectives, main issues are we're going to talk about quickly over the next 10 to 12 minutes is why HFpEF is becoming a big discussion point. We'll briefly touch upon pathophysiology, and we'll identify specific HFpEF patients at high risk for readmissions and mortality, and talk about some of the limited options for reducing readmission rate among these patients. So why is this a big topic? Well, the prevalence has been increasing, particularly with age. You can see on the left-hand side of the screen, when we look at the Get With The Guideline registry, when they looked at the patients who were admitted for heart failure, there was a rising proportion of patients who had an ejection fraction above 40% and particularly above 50%. And this was estimated out, and this data is a little dated at the moment, but they expected that heart failure with preserved ejection fraction would become a bulk of the patients that we see in the hospital side. Now, looking at the right, this is looking at prevalence of heart failure with preserved ejection fraction when compared to heart failure with reduced ejection fraction. And we see the prevalence does increase with age, whereas HFrEF, there's a modest increase with age. And the particular group that increases with age was seen in the women's cohort. And this was out of the study looking at the southwestern European population and their cohorts longitudinally. So characterizing overall HFpEF admissions, this was a study from the group out of Cornell, and Dr. Goyle looked at the national inpatient registries and discharges, and they found that from over 5 million acute heart failure hospitalizations, close to 46% were related to HFpEF. And when we break down the admissions a little bit further, we see that there was a higher prevalence for women to be admitted for HFpEF. And you can see that on the bar graph on the left side. When you look at male and female, the blue is the proportion of HFpEF admissions. And when you look at the right, we see that when you risk stratify over age, that the prevalence of hospital admissions actually increase as patients get older with heart failure with preserved ejection fraction, again, as signified by the blue bars compared to the red. So why is this such a complex disease process? Well, what we've learned is that this is not just a disease of the heart, but this is a disease of multi-organs, including lungs, visceral adiposity, kidneys, skeletal muscle with increased adipose infiltration. All these together create that symptoms of breathlessness that a lot of these patients feel, and that sedentary lifestyle, metabolic stress, remodeling of the myocardium, aging, and vascular stiffness leads to that reduction in cardiac diastolic reserve and stroke volume reserve. And this leads to this very complex diagram of how this sort of interplays with the heart. And unfortunately, when we isolate the heart from everything else, we realize that none of our treatment strategies have been effective. So this sort of takes a deep dive into the actual cardiac manifestations, but we know that this is more of a systemic disease process. So getting to the meat of the presentation and really identifying those high-risk patients with heart failure with preserved ejection fraction. And how do we do that? We know that all patients with HFpEF, as we're becoming a little more sensitive in diagnosing this disease entity, we realize that not all of them are created equal. And this was signified really well by Dr. Shah at Northwestern when he took a look at his cohort in his HFpEF clinic in Northwestern, where they actually took a deep dive into the data to see if there was any type of different groupings that he can get when looking at all of the available data, whether it's labs, inpatient admissions, as well as echocardiographic data. He was able to risk stratify these over three distinct phenotypic groups, looking at the group 1, which was the BNP deficient syndrome, the group 2, which was obesity cardiometabolic, and group 3, which was the RV cardiorenal HFpEF phenotype. And when he looked at long-term outcomes, whether stratified by cardiovascular death or hospitalizations, he saw that this group 3, that RV failure and cardiorenal phenotype, had the worst outcomes amongst the three groups. And what was interesting is this was again seen in looking at the TopCat data. Now, this is out from Dr. Seeger and the group out of UT Southwestern. Actually, Dr. Tang from Cleveland Clinic was included in this study as well, where they took a look at phenomapping the TopCat population to see if there's any differences between the patients that were enrolled in the study. And they did see a distinct groupings between three different groups, and really we'll sort of look at the phenogroup 1, which mimics the phenogroup 3 that Dr. Shah saw at Northwestern. And they saw that these patients had a worse cumulative incidence of the primary composite endpoint, which was all-cause mortality and heart failure hospitalizations. And this sort of continued as they took independent looks at all-cause mortality, major cardiovascular events, and heart failure hospitalizations. And when you take a look at this phenogroup 1, what kind of distinguished them amongst the three is that these patients tended to have higher BUNs, effectively lower GFRs, and higher creatinines. They were anemic compared to the other two phenogroups. They had a relatively high NT-proBNP, and with the averages around the thousands, and a higher BNP as well. They had a little bit of electrical remodeling too. They had a longer pure restoration of 107 milliseconds compared to the other two phenogroups over less than 100 milliseconds. And echocardiographically, they had higher LV mass, more dilated left atriums, and a higher peak tricuspid regurgitation velocity. And when looking at the different sort of angle of looking at phenomapping, this was a study from Dr. Cohen et al., where they took a look at not only echocardiographic data, but also biomarkers. And they found that looking at the whole cohort, not just the cohort that may have benefited from spironolactone, but when they look at the whole the holistic data of it, they did find three distinctive phenogroups as well, with this third group being this cardiometabolic, with worsening CKD, higher levels of inflammatory and fibrotic markers, with more cardiac remodeling. These patients were the ones who were higher risk for heart failure admissions, and as well as all-cause death. So really, even though that we were able to find that this HFpEF group is fairly heterogeneous, there are distinct groups, and able to identify the high-risk groups, particularly the ones with CKD, anemia, the milieu of high-risk features. So what are the strategies to reduce, specifically readmission? We know that there isn't anything that has helped to reduce mortality, morbidity in this patient population. And this was really signified by many studies looking at different drugs in general, sildenafil, spironolactone, the ARBs, and beta blockers. And nothing came up positive when looking at all-cause death and also heart failure hospitalizations. And then, TopCat and Paragon, looking at spironolactone and sacubitril/valsartan respectively, did not show a big benefit, although spironolactone, when stratifying per region in the study, showed a better benefit in terms of reducing heart failure hospitalizations. Both drugs were relatively disappointing when it came to the studies actually showing their data. So what could potentially work? Well, this is a little bit of thinking outside the box, but also trying to see and look at these patients at a different way. So bariatric surgery and rapid weight loss, we know that this can be very helpful, not only symptomatically for patients, but interesting enough can have a hemodynamic benefit in the cardiovascular system as well. And this was a meta-analysis from Dr. Reddy et al. From the Mayo Group, looking at different papers looking at weight loss, specifically bariatric surgery weight loss, and how the hemodynamic effects were associated with that weight loss. And they showed that the bigger percent change in weight loss, the better cardiovascular effect you had, not only in in reducing cardiac output, mean arterial blood pressure, and whole body oxygen consumption, but also hemodynamically, where you saw a reduction in right atrial pressure, wedge pressure, and pulmonary artery pressure. So weight loss not only has that benefit from a symptomatic standpoint, can have a profound physiologic effect, especially with the rapidity of weight loss. Sort of a new entity which has been around for a few years, but ambulatory clinics for IV diuretics. This has been sort of studied a little bit more further recently with the hopes of reducing hospital admissions. And this is out of the group from Brigham and Women's, where they looked at their own data, and they had a ambulatory clinic where patients would come in for IV diuretics. And their main point was to see, was it effective in terms of weight loss and decongestion, and then looking at outcomes, whether they had hospitalizations, worsening renal failure, safety, things like that. And they showed that despite, irrespective of the etiology of heart failure, whether it was HFrEF or HFpEF, that both groups were decongested effectively, signified by urine output, clinic weight loss, and home weight loss. And this was stratified amongst all the groups, whether it was low dose diuretics versus very high dose diuretics. And when they looked at the outcomes, they were able to reduce hospitalizations at 30 days and 60 days. And all-cause mortality was low with this, even with these aggressive diuretic regimens. And also there was a low incidence and no incidence of severe worsening renal failure or any hypokalemia. So safe effectiveness is still to be seen. And CardioMEMS, probably the one entity with the best data, looking at actual data from the Champion trial, and they were able to show that after implantation, there was a significant reduction in heart failure hospitalizations, stratified amongst any ejection fraction, even seen particularly in the greater than 50%. So definitely an effective treatment, and important in these days where remote monitoring is paramount during this pandemic. New are these specialized HFpEF clinics, which have been seen in a few centers, especially in the US. And this is to take a deeper dive into the patient itself, to specifically phenotype them and try to target therapies, research, and to ensure that we're not missing phenocopies, particularly amyloidosis, which has been a little bit more prevalent than recently thought. And this is sort of signified by the group out of Johns Hopkins, where they saw that of the 100 biopsies they did from their HFpEF clinic, 14% actually had amyloidosis. So overall, we know the HFpEF prevalence is rising, as well as admission rates. This is a complex pathophysiologic process and has multiple areas that contribute to the lack of treatment options. With phenomapping, we can probably identify and risk stratify patients better to identify the ones that may have a higher prevalence for readmission rates. And then treatment options are limited, but potential strategies such as cardiomems, diuretic clinics, and the specialty clinics like HFpEF, which need to be studied further, may reduce healthcare utilization and cost in general as well. So thank you, and I appreciate the opportunity.
Thank you very much, Dr. Bhattacharya, for that overview of HFpEF, and we'll look forward to the Q&A. There's a lot of questions rolling in, which is terrific. It's my pleasure to introduce the next speaker, who is the co-moderator of this symposium, Dr. Faris Bader, who's director of the heart failure section at Cleveland Clinic, Abu Dhabi, and serves as vice chairman of cardiology. And it's important to note that Dr. Bader was also at one time a member of a very large and successful heart transplant program in the US at Salt Lake City. So we'll look forward to the presentation today by Dr. Bader.
Thanks again for joining us in this special Cleveland Clinic heart failure webinar. We've heard about heart failure with reduced ejection fraction and heart failure with preserved ejection fraction and the risk of hospitalizations. I will take you now through acute heart failure and discuss specifically the importance of cardiorenal interactions. There are no relevant disclosures related to this presentation. So I'll be focusing mostly on important concepts in the pathophysiology and the dialogue between the heart and the kidney, and reflect on the management and specifically why decongestion is so critical. This is what we call the lifetime three-phase terrain of readmission risk in heart failure patients to the hospital. And of course, it always starts with the initial phase of increased risk of readmission once the diagnosis is made. We then go through a plateau phase where that readmission risk is less because patients are used to taking their medications and are used to self-care behavior. As their disease progresses, we then go through a phase of increased risk of readmissions to the hospital, and that's when we start considering patients as advanced patients and start thinking about advanced therapies for them. The classic pathophysiology in acute decompensated heart failure was always based on the fact that there is an initial cardiac insult that leads to hemodynamic decompensation, but also leads to neurohormonal activation. Between the hemodynamic decompensation leading to the increase in preload and afterload, as well as the decrease in cardiac output, and the activation of renin-angiotensin-aldosterone system, as well as the sympathetic nervous system and other neurohormonal systems, we see the signs and symptoms of heart failure in a decompensated fashion. Of course, there's always the concept of non-traditional pathophysiology, which depends mostly on fluid shifts in patients with certain phenotypes of heart failure, specifically heart failure with preserved ejection fraction, where not necessarily volume retention leads to heart failure, but potentially fluid shifts from more of the capacitance blood vessels closer to the heart and back to the lungs to present with acute decompensated heart failure, mostly in the form of pulmonary edema. So this is what I refer to by the dialogue between the heart and the kidney. The decreased cardiac output and blood pressure could lead to activation of neurohormonal systems. This leads to decreased renal artery pressure, as you see on the left side of the screen, increased venous pressure, and of course, increased renal capsule pressure. Together with the sodium and water retention and the decreased renal blood flow, we end up with decreased urine output. But as a result, it then becomes a sequence of decreased perfusion as well as increased congestion. And the net result is what results in the worsening of cardiorenal syndrome in the process of acute decompensated heart failure. To the right side of the graph, we see some of the ways where diuretic resistance ends up developing in the management of acute decompensated heart failure, something that we have to deal with at times, and we have to use specific strategies to overcome when we're struggling with getting people decongested. This came from the American College of Cardiology expert consensus decision pathway in acute decompensated heart failure, and brought on this concept of trajectory check in acute decompensated heart failure. Basically, as we're managing patients with acute decompensated heart failure, we really have to always assist them for improvement or lack thereof, and deciding how we can optimize their management as we move from the early acute phase here to the transition to oral therapy phase here to the outpatient optimization. This trajectory assessment is critical in deciding the next step in their management and in shortening their stay at the hospital while optimizing their care and importantly putting them on life-saving therapies before they go home. When we talk about cardiorenal syndrome, we talk about 5 types of cardiorenal syndrome, but type 1 cardiorenal syndrome is the one that relates to the worsening of renal function in the setting of acute decompensated heart failure. And this is the cardiorenal syndrome we're referring to in this presentation. People looked in depth to decide what causes cardiorenal syndrome in acute decompensated heart failure. And for a long time, we thought that reduced cardiac index is the main mechanism in these patients. This is a nice study that showed that for different types of renal parameters, indeed, the reduction in cardiac index did not really make a difference in any of these parameters. So if we look at eGFR, BUN to creatinine or creatinine, for different ranges of cardiac index, it really didn't matter what the index was when it comes to these different parameters in acute decompensated heart failure. So what seemed more critical is actually the congestion rather than the decreased perfusion. But ultimately, again, like I showed in the first slide, it's a combination between the decreased perfusion and the increased congestion, but we're learning more and more and more that it is the congestion that is playing the major role in worsening renal function in the setting of acute decompensated heart failure, and is the target that we need to kind of go after when it comes to improving the outcomes for these patients and help them go home in a state that will keep them out of the hospital for as long as possible. Every time we talk about acute decompensated heart failure, we remind our trainees and students to always assess for perfusion and congestion, because the patient is going to be either well perfused or not well perfused. The patient will always be congested or not congested. And for a long time now, we knew that simple clinical signs like the presence of JVP or S3 can influence outcome post discharge with acute decompensated heart failure as a surrogate for worsening congestion and the fact that the patient left the hospital in a decompensated state. This is from the Everest study, which looked at vasopressin antagonists in the management of heart failure. But the relevant point here is that patients who are congested will always have worse outcomes than patients who are not congested. Importantly, the higher the dose of diuretics that they're on, the worse their 30-day outcomes. This is very elegant. This is a study that I consistently show in my presentations on cardiorenal interactions in acute decompensated heart failure. And this is a study that looked at intrarenal hemodynamic evaluation by Doppler ultrasonography in heart failure. I know that Dr. Starling likes this study a lot because it really highlighted the importance of venous flow patterns in relation to filling pressures and in relation to outcomes. So if we look carefully here and understanding that the monophasic venous flow pattern is the worst flow pattern in these venous patterns on the intrarenal hemodynamic Dopplers, the correlation was strongest with things like the pulmonary capillary wedge pressure and the central venous pressure, but it wasn't actually statistically significant for the cardiac index. And as a matter of fact, if you look at the outcomes as correlated based on the venous flow patterns here, together with the filling pressures, you'll see that the discontinuous form of the venous flow pattern together with high right atrial pressure had the absolute worst outcomes compared to the high right atrial pressure with a discontinuous flow pattern. And of course, the best was when patients had low filling pressures indicating less congestion. So as we move from this congested state to the decongested state, where patients are free from clinical congestion by symptoms, of course, but importantly by physical examination. And as we're trying to make sure they leave the hospital in this state so they don't have to come back to the hospital very soon, we have to keep in mind reasons for why patients continue to have residual congestion. And of course, advanced renal disease will always continue to be a critical reason for why these patients might not be decongested adequately. But is worsening renal function an ominous prognostic sign in patients with acute heart failure? Not when you decongest patients properly. And again, this study elegantly shows that when patients leave the hospital with worse renal function and congestion, their outcomes at the bottom here are the worst, followed by patients who are congested, even if the renal function did not worsen. So if the renal function stayed okay, but patients are congested, their outcomes are worse than patients who left the hospital with congestion, left the hospital with no congestion and with worsening renal function, which tells us that the transient worsening of renal function is not really the end of the world when you're managing these patients. We have to daily assess patients' way to decide if they're getting decongested or not decongested. We have to assess their intake and output, of course, in addition to the other important things that we do when it comes to signs and symptoms, electrolytes, and renal function. The dose trial showed us that there is not really significant difference between high versus low dose strategies in acute heart failure management, bolus versus continuous infusion. So you use whatever strategy works for you. We know that higher doses will end up helping patients decongest faster, will lower their NT-proBNP more, and will shorten their length of stay, even though that did not really achieve statistical significance. But again, there is no harm in using higher doses of diuretics. I'm showing this dialogue again between the heart and the kidney to emphasize that this is a multidisciplinary problem. So keep in mind that when you're starting to see cardiorenal syndrome worsening, contact your nephrology colleagues and work as a team to overcome this problem and get patients safely out of the hospital. Overcoming diuretic resistance has multiple ways. We can always add other loop diuretics, or increase the dose of loop diuretics, but we can add thiazide diuretics. Sometimes we have to use vasoactive medications in the form of vasodilators or sometimes inotropes to overcome this resistance. Of course, we sometimes end up resolving into things like renal replacement therapy. I would advocate here that if you're not sure about the volume status and you're facing worsening renal function in the setting of acute decompensated heart failure, hemodynamic assessment might not be a bad idea. Always keep in mind other causes for renal dysfunction, other medications, contrast media, important medical issues that could potentially influence the renal function in the setting of acute decompensated heart failure beyond acute decompensated heart failure. And that's part of that multidisciplinary approach that should happen in conjunction with the nephrologist. Remember that patients need to have multidisciplinary follow-up for their heart failure once they're discharged. And remember that every acute decompensated heart failure needs to leave the hospital, needs to have an appointment to see the heart failure team within 7 to 14 days after discharge. So in summary, type 1 cardiorenal syndrome complicates the management of acute decompensated heart failure and carries a significant morbidity and mortality, multiple neurohormone and hemodynamic pathways contribute to its development and progression. Venous congestion systemically and intrarenally seems to be the major final common pathway in the pathophysiology of type 1 cardiorenal syndrome. The management of acute decompensated heart failure, when complicated by worsening renal function, requires a multidisciplinary approach and a careful assessment with close follow-up. The key approach is relieving congestion, sometimes even at the expense of mild renal dysfunction, and initiating therapies known to improve long-term outcomes. And with that, I would like to thank you for your attention. Fantastic. So Randy, we've heard about heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and then acute decompensated heart failure and some of the cardiorenal challenges. Let me welcome again our co-speakers for the heart failure session of this Cleveland Clinic webinar. I see questions within our question and answer box, and I'll get right to it and start by asking perhaps Hussam this question. The use of SGLT2 inhibitors, what do you think as far as sequencing them as a first line along with beta blockers, since they don't really require dose optimization? So once a day dosing, do it and get done with it.
I think that's a very good question. No, the way most of us heart failure physicians approach this is usually we start the medications the way they were chronologically studied in the trials. So the benefit seen in the DAPA-HF and the DECLARE TIMI-38 was in patients who are really optimized in terms of the use of medications, including ARNI. So it's a medication that I tend to, and we tend to start sort of closer towards the end of the hospitalization for hospitalized patients. I'm very particular about which patients I use them in. So I actually follow the clinical trials. They have to have had prior hospitalizations, elevated NT-proBNPs, and that's regardless of whether or not they're diabetic or not. So if a patient's had a hospitalization, I was able to really up-titrate their medication, including the diuretics, to decongest them appropriately. This is a medication that I start 1 or 2 days prior to discharge. No real rhyme or reason, but the benefit that was shown in terms of reduction in CV death and rehospitalization was in patients who were already really well optimized in terms of the other guideline-directed medical therapies. So that's my approach usually.
So Ferris, let me see if I can stimulate some conversation here. So I'm looking at the chat, and there's a lot of questions about SGLT2 and ARNI. That's most of them. And some of these are pretty interesting, like, what do you do after a right heart cath? How about in HFrEF patients with low cardiac output, role of ARNI in acute decompensated heart failure? And maybe my favorite question here is, and I'll read it, how does the panel respond to the recent push, including KOLs, which means key opinion leaders, I don't know who they are, for upfront initiation of SGLT2 ? Hype ? So yeah, there's a lot of stuff that's popping up now by Dr. McMurray, Dr. Milton Packer, and others, quote unquote, pushing SGLT2. And as you have already pointed out, other than the data from the Soloist trial with sotagliflozin, it's outpatient experience, more or less. So I think any comments, well, I guess in acute heart failure, really all you can refer to is Soloist, where it was in the setting of the hospital. We don't have sotagliflozin in the US, and it's not even going to go to the FDA because the drug's not available in the US. So that's a moot point. And as Dr. Bhattacharya knows, There are active trials on SGLT2 inhibitors with higher ejection fractions. We got a glimpse from Soloist in a subgroup with preserved ejection fraction. So I know we can't say anything definitive, but the audience will probably want to hear from Dr. Bhattacharya a little bit about SGLT2, and you, Dr. Galib, if you want to expand your thoughts on ARNI in the setting of low output heart failure, more severe heart failure, and you know, be careful, because you know we've published some papers on ARNI and Swan-Ganz catheters, so we'll help you out if anything's needed.
I don't know if Dr. Bhattacharya is able to participate, but I'll quickly opine on an ARNI initiation on the inpatient setting as studied in the Pioneer trial. You know, these were more sort of we would call subclinical outcomes or hospital-based outcomes, not really hard outcomes per se. Importantly, ARNI can lead, when started in the inpatient setting, they can lead to profound hypotension that may then limit the maintenance or up-titration of other guideline-directed medical therapies that are known to have a hard outcome in terms of mortality and morbidity. So it's something that we tend to tailor towards the end of the hospitalization or even leave for the outpatient setting. Primarily for that, we really ramp up the beta blocker, we work on decongestion, want to make sure no ARNI initiation limits in terms of hyperkalemia or renal dysfunction, our ability to really decongest the patient. In terms of low cardiac output or you know, hypotension, when it starts with ARNI, it can be, you know, very gnarly, process. So we're very careful in starting patients who have blood pressure less than 90, but I can see the smirk, and I know you're going to opine and give your opinion on that.
No, I think you're totally correct. And yeah, Pioneer's endpoint was a change in N-terminal BNP. And even though the curves were exciting that were published in the New England Journal, some of them weren't pre-specified endpoints. And there's an ongoing trial called Paraglide, which is basically to do the repeat Pioneer, but with ejection fraction over 40. So Novartis is sponsoring that. We'll see what that shows. It's change in terminal BNP. We know from Paragon that we didn't quite make the mortality endpoint. And in the US, sacubitril/valsartan, now the FDA has expanded the use. I don't know if that's true in other parts of the world. I don't think it is, but so the wording now is with less than normal ejection fraction. So
yes.
just very briefly, we do have a publication that was in the Journal of Cardiac Failure that was led by one of our fellows that looked at patients that had a Swan-Ganz catheter that were treated with nitroprusside or inotropes that actually had the sacubitril/valsartan started in the intensive care unit. So that's under very controlled circumstances. And I agree with you completely. In the hospital, we're very cautious. We usually will use valsartan kind of as a test to see how the patient does with that, and then transition in appropriate patients to sacubitril/valsartan. Sean, perhaps you would like to make some comments about what you see coming.
Thank you, Dr. Starling. I think it's a really exciting time for heart failure. I think the amount of medications coming out now showing a lot of benefit is pretty exciting, especially for young staff, where we've looked at mainly the drugs from the 80s and 90s, and now we're starting to see some improvement, at least some innovation. From the HFpEF side, particularly, it's going to be exciting. I think there's a big push from the NIH to study this a little bit more in depth because we've had so many failed trials. I'm interested to see Paraglide, although I think there might be a little bit of a mimicking of Paragon, where maybe that ejection fraction of 40 to 49% might have the best benefit, or people with higher higher NT-proBNPs, but it'll be interesting to see post-discharge if that can help reduce hospitalizations. I think also the SGLT2s are going to be very exciting. You know, a lot of the data I talked about in my talk is North America centric, which is a little unfortunate, but I think Dr. Carolyn Lamb is making a huge push internationally to really study these HFpEF patients and really seeing that diabetes plays a huge role, especially in Southeast Asia and Asian countries. And I think the phenotype is much different because obesity is not as prevalent as it here is in the United States. So NT-proBNP is a little bit higher internationally and more of a lean phenotype with more coronary disease. So I think it's heterogeneous not only in the United States, I think it's heterogeneous across the world. And I think understanding that's going to help better treat that. But again, I think SGLT2s are going to be very exciting. And I think they're going to show their data this year at ESC. So everyone's going to be waiting with bated breath.
Paris, I don't know if you want to tackle this question. I think it would fall into your lap. It says, in resistant diuretic, is dialysis play a role? That's kind of a loaded question.
Yeah, so I mean, I'll just call it renal replacement therapy. And I mean, we try all kinds of combinations. Like I said, we can increase the doses of, and we tend to use high doses of loop diuretics, sometimes in a continuous drip format. We add thiazide diuretics. And if we feel that adding more vasoactive medications, depending on the patient's hemodynamic state and especially perfusion, we sometimes end up with vasodilation causing better response to diuresis, and you know, every now and then we feel like the patient might benefit from a short-term use of inotropic therapy, and that all could result in improved response. We try to kind of leave renal replacement therapy as a last resort, but usually, you know, ultrafiltration in randomized clinical trials, the way they were conducted, at least, did not result in better outcomes than diuresis. But of course, the long-term argument on the use of ultrafiltration, especially as was concluded from the CARES-HF trial, for example, is that it wasn't necessarily used the way we use it most practically in our patients in that trial. So we still find a place for renal replacement therapy in certain refractory patients when they're truly refractory.
The one footnote I would make to that, and this is a very practical comment. So believe it or not, I walked in a room on this past Tuesday morning, patient admitted to me, gained 50 pounds in 5 days, well documented. I don't know how he did it, but he did it. So he was on intermittent hemodialysis. That patient I elected to move to our heart failure intensive care unit, hook him up to ultrafiltration to try to expedite his volume recovery, if you will. But as Dr. Bader said, we have absolutely no mortality data on dialytic therapy, but from a practical standpoint, we go to ultrafiltration fairly commonly when we want to mobilize fluid, just from a very practical standpoint, because, and this man was on 10 milligrams 3 times a day of midodrine. You can imagine our dialysis colleagues couldn't get very far.
Yes.
And I don't know what's going on, but it seems like every other patient's coming in on midodrine these days. They're also sick with advanced heart failure. There is a question about ivabradine, and I think maybe my outside US colleagues may have more experience than we do. And the question is not ivabradine used in refractory heart failure?
Hassam, would you like to tackle this and express how we approach ivabradine, even though, so the region, just to preface that the region goes by either American or European guidelines. So ivabradine was approved for use here in the region a long time before the FDA approval. But I think it was more abused than properly used, because of multiple reasons. But Hussam, would you like to reflect our experience with adding ivabradine?
You kind of mentioned it, Firas. So if you just look at the patients who are coming to our clinics for referrals, you'd think that ivabradine is the most effective heart failure medication. Invariably, they're all on it. It's used for other indications other than heart failure, actually. Our approach is to really try and see if there are any reasons why the patient isn't optimized on beta blockers or why the heart rate is really elevated. We look for anemia, we look for issues with deconditioning. And then if the beta blockers are truly optimized, then we may use ivabradine in select patients. Now they have to be in, we follow the trial, they have to be in sinus rhythm. And we try different beta blockers sometimes, primarily because the data for ivabradine is not the most solid, especially in that pivotal trial that led to its approval. However, if there are a select group of patients who have really high heart rates, in spite of adequate beta blockade where we use ivabradine, we usually see no role for ivabradine in the inpatient setting or its initiation in the inpatient setting, because that's not how it was studied. But yes, we see a lot of patients on ivabradine coming into our clinics on low doses of bisoprolol or metoprolol.
So in short, we end up stopping ivabradine more than actually starting it, because we find that it's used in the wrong place. The idea here is that it shouldn't be used for refractory heart failure for sure. It's for chronic heart failure patients in sinus rhythm who are well treated with beta blockers and still have heart rates that are more than 70. But we don't just see many of these patients. I don't know how your experience is in Cleveland, but we don't have a high percentage of people who are well treated with beta blockers in sinus rhythm and they still have high heart rates. What do you think?
Yeah, I'll be brief, but I expect I have less than 5 patients on ivabradine, and to go to ivabradine, the patients are either on the equivalent of 50 milligrams twice a day of carvedilol and they're still tachycardic, then I will use the ivabradine, or they must have some absolute intolerance to the beta blocker. And insurance companies in the US can make it challenging to access ivabradine. And I just want to give Dr. Ghalib a very complimentary note in that a few years back, Dr. Tang and I tried to launch a clinical trial with ivabradine in the Heart Failure Network, and Dr. Brunwald basically blocked it and said, all you need to do is optimize the beta blockers and you don't need ivabradine. So we never got to do that trial. And he said the same thing, that people don't optimize beta blockers. So we really try to emphasize that point.
Excellent. Well, I think it's time to move to the rest of the session here. This was an excellent discussion. And we can continue it in our second question and answer period. So it is now my pleasure to introduce our fourth speaker for the night. And it is a pleasure to introduce Bjorn Tannes, who is a heart failure and transplant cardiologist from the Cleveland Clinic in Ohio. And I can just summarize Bjorn's biography by saying he's a very, very well-traveled guy. He did his medical school in Germany, but part of it was also spending time in South Africa as well as in England. His training places included Emory, Temple, University of Pittsburgh, as well as Columbia in New York, and he ended up on faculty at the Cleveland Clinic in Ohio. Bjorn, I look forward to your presentation on diabetes and heart failure.
Wonderful. Good evening to Abu Dhabi. Thanks ever so much for having me. Assalamu alaikum. It's a great pleasure to participate in this series. I have no financial disclosures. So please allow me to start with my case. I have a 59-year-old Caucasian woman. She has a non-ischemic cardiomyopathy. Her ejection fraction is 33% on a cardiac MRI. She also has hypertension, diabetes type 2. She's obese with a BMI of 34. She has CKD 3A with a GFR of 48. Her blood pressure is well controlled, 118/76. Heart rate is 62 on the physical examination. She's warm and well perfused. Her heart is regular. She has a 2 out of 6 holosystolic murmur as well as NS4. Her lungs are clear and she has a trace lower extremity edema. Some more data, her EKG, sinus rhythm. She has a narrow QRS complex. Her creatinine is 1.68. Her hemoglobin A1C is elevated at 8.2. Looking at her medication, she's on carvedilol 37.5 twice a day. She's also on sacubitril valsartan 97/103 twice a day, spironolactone 25, diuretic torsemide, and she's also on semaglutide 1 milligram subcutaneously once a week. So in summary, she seems eubulemic, and classification will be ACC-AHA class C heart failure, New York Heart Association class 2. Now, if we look at the patient, the question is, can we optimize her medical therapy for her heart failure with reduced ejection fraction, as well as for her diabetes? And the answer is obviously yes. Before we start with the selection of therapy, let's have a look at the diabetes. And it's very interesting because the diabetes on the planet is significantly on the rise. This is a very nice paper looking at the global diabetes prevalence and burden in the entire world, published in 2019. And you can see that prevalence of diabetes continues to rise with age, which is to be expected, and it kind of plateaus off at the age of around like 55 to 60, with the prevalence there reaching around 20%. If we see and look at an estimate of all the patients on Earth, you can see that it's almost 500 million, which will reflect to 9.3% of the world population. I think this is a quite striking number. Predictions are that up to in 2045, we will have more than 700 million people who suffer from diabetes. Now, this is a real stress to the cardiovascular system, not only for the microvascular disease, nephropathy, retinopathy. There is no nephropathy without retinopathy, as well as neuropathy, but even more for us cardiologists and primary care physicians, particularly interested in cardiovascular disease. This puts a high stress on the macrovascular diseases, coronary artery disease, stroke, cerebrovascular disease, and obviously also peripheral artery disease. Now, crossing the roads of cardiology and endocrinology, it is important that we have a proper roadmap to tackle this combined disease burden. For risk factor modification, it is quite important that we have our patients on the appropriate medicines. Statin therapy is indicated for any diabetic who has established atherosclerotic cardiovascular disease. And in diabetics who are older than 40, we use our risk calculator, and they have to be on a statin. It's just a question, are they going to be on a high intensity statin, or are they going to be on the low intensity statin? More than 7.5% risk, a high intensity statin is indicated. If it comes to blood pressure control, there are, depending on the guidelines, slightly differences. ACC-AHA guidelines recommend to bring the patient out of stage 1 hypertension, which will be less than 130/80. ADA guidelines recommend bringing the patient out of stage 2 hypertension, which will be less than 140/90. Aspirin might be considered if the risk is higher than 10%. If we look at the medical therapy for diabetes in established cardiovascular disease, 3 options are available for us: metformin, GLP-1 receptor agonists, and then the SGLT2 inhibitors. Now, if we have heart failure, if we have no heart failure with reduced ejection fraction, but in example, just an isolated coronary artery disease, we can pick between GLP-1 receptor agonists or SGLT2 inhibitors. If we have patients with reduced ejection fraction, defined as per American guidelines with an ejection fraction of 40 or less, SGLT2 inhibitors are the preferred choice. How do they work? Well, they inhibit the sodium glucose pump in the proximal tubular cell, as you can see here, which will lead to decreased plasma glucose, decreased blood pressure, and also to a decreased glomerular hyperfiltration. If we look on the cellular level, it is not entirely clear at this moment in time what all of these mechanisms are. There is for sure a direct myocardial effect as well as a systemic effect. Very nice review article here by Loperchot in JAG. Two big trials investigated the efficacy of SGLT2 inhibitors. Both enrollment, the two enrollment criteria, major enrollment criteria, were heart failure with reduced ejection fraction and New York Heart Association class 2 to 4 heart failure. There is the DAPA-HF trial, dapagliflozin in patients with heart failure and reduced ejection fraction, published in the New England in November 2019. And then we have the Emperor Reduced trial that was published in October last year, cardiovascular and renal outcomes with empagliflozin in heart failure. Now, if you look at the results, I think they're really striking. DAPA-HF, the heart failure hospitalization showed a striking relative risk reduction of 30%, and Emperor Reduced very similar 31%. And if it comes to cardiovascular death, a striking 18% relative risk reduction in DAPA-HF and 8% in Emperor Reduced. I think this is quite striking and impressive, and this is the primary composite endpoint. Now, taking the SGLT2 inhibitors to the bedside, I think here it is where it really matters. We're providing direct care, we're executing the guidelines, we're executing our trial results. So in general, SGLT2 inhibitors are contraindicated in type 1 diabetes because of the risk of ketoacidosis. So it's quite important to pay attention to this. Lactation is also a contraindication. We have to be cautious with fungal genital infections, UTIs. This is not that uncommon. I'll counsel all my patients about this. Volume depletion, our patient is already on an ARNI and on spironolactone and on torsemide, and now we're adding another diuretic to it. So volume depletion is an issue, and we might have to back off on or back down a little bit on the loop diuretics. Pregnancies, UTIs can occur, ketoacidosis regarding of the blood sugar level. I've seen one case in the ICU with this several years ago, so that is a true phenomenon, as well as pancreatitis and then very rare Fournier's gangrene. How do we start them? Dapagliflozin is 10 milligrams daily, and there is no titration. That is the same as for empagliflozin, 10 milligrams, no titration. We have to look at the kidney function though. Dapagliflozin needs to be reduced to 5 milligrams daily if the GFR is less than 45. If it's less than 30, unfortunately, it's contraindicated. However, we then have the alternative of switching to empagliflozin, and we can go to an eGFR of less than 20. Now, back to our patient. What did I design? I initiated metformin 500 milligrams twice a day, keeping in mind that I counsel the patient about the GI side effects, and we can up-titrate this further and monitor for vitamin B12 deficiency that can occur with metformin. Dapagliflozin, I opted for 10 milligrams PO daily, as well as a high-intensity statin, as her risk was over 14%, 20 milligrams daily. And because I start the dapagliflozin and the patient is already on spironolactone and on an ARNI, I want to recheck a basic metabolic panel in 2 weeks. time to make sure that the kidney function is stable. Thank you very much. It was a great pleasure participating, and I'm looking forward to a very fruitful discussion. Shukran.
Thank you, Bjorn. This was fantastic. Moving on, it is my pleasure to introduce Dr. Viviana Navas, who is the Director of Heart Failure, Heart Transplantation, and Mechanical Circulatory Support at the Cleveland Clinic in Florida. And she'll take us through an exciting topic on novel interventions in refractory heart failure.
Good evening, everybody. I'm Dr. Viviana Navas. I'll be presenting the novel interventions in refractory heart failure. Where do they fit? I want to thank my colleagues in Abu Dhabi for inviting me to be part of this wonderful webinar. I hope you enjoy my talk. So I'm going to take you through a case presentation during the whole talk. I think this case illustrates what we're doing right now with patients with refractory heart failure. So this is an 82-year-old man that came to us from Venezuela. He actually flew in that same day that he came to our clinic. When he came in, he was complaining of a 25-pound weight gain. You could see he was in anasarca, very short of breath, functional class 4. And he came with a history of multiple hospital admissions for decompensated heart failure in the last year. So he had a history of paroxysmal AFib, a history of coronary artery disease with 2 prior bypass surgeries. The last one had been in 1995, and he came with an echocardiogram from an outside hospital that showed an ejection fraction of 30% with severe mitral regurgitation and moderate to severe tricuspid regurgitation. As you can see, the only guideline medical therapy he was able to tolerate was eplerenone. Everything else was just diuretics. He could not tolerate beta blockers or ACE inhibitors because of hypotension and bradycardia. On physical exam, he was a little bit hypotensive with a blood pressure of 92/44, and he was clearly volume overloaded with JVD, with edema bilaterally, and a very significant murmur on auscultation. So the patient was diagnosed with acutely decompensated heart failure, and we sent him to the emergency room to be admitted to the heart failure service. On admission, we performed an echocardiogram, and as you can see, he has global hypokinesis with a low ejection fraction of around 20–25%. And when you put color here, you see torrential mitral regurgitation with a very large PISA, and we could call this functional MR. Chest X-ray showed pulmonary edema with small right pleural effusion, and very importantly, the EKG was sinus with a heart rate of 60 and a QRS of 106. We decided to perform a right heart and a left heart cath to see where his numbers were. He had pulmonary hypertension with a very elevated wedge of 35 that correlated with LVDP, a cardiac output of 4 and an index of 1.9, so both very low. His left heart cath showed stable coronary artery disease with patent bypass grafts. So during this hospitalization, we very aggressively diuresed him. He diuresed around 12 liters. He felt much better clinically. We were able to start him on low-dose beta blocker and ARBs. He received some blood, and his renal function remained stable during hospitalization. So the question is, what's going to be our next step in management? So continue guideline medical therapy plus really close follow-up outpatient. Do something about the mitral and tricuspid valve, either surgically or transcatheter approach. Start thinking about advanced heart failure therapies like an LVAD, or is it too late for this patient? Do we send him for palliative care? So we decided to do the first one. We decided to continue guideline medical therapy and follow him very closely outpatient. But 2 weeks later, he presented again to the emergency room, now with a 15-pound weight gain, again, volume overloaded, short of breath, even though he had been very compliant with medications and diet and fluid restriction. So we admitted him again to the hospital with acute and chronic heart failure, started diuresing him again, trying to optimize his medical therapy. So at this point, we're thinking, well, this patient, despite everything that we're doing, is still having heart failure. So we're dealing with refractory heart failure. So this is where this patient fits, right? Stage D, refractory end-stage heart failure, where the patients are markedly symptomatic despite guideline medical therapy, despite diuresis, with functional class 4 symptoms. So these are patients that, besides being very symptomatic, have recurrent hospitalizations. It's extremely hard to keep them home, no matter what we do. And this is our famous staircase of what we do for all these patients from the moment we start with prevention to all the available medical therapies that we have. But then when we reach this point where these patients are at stage D, really the options are limited. And we either send them to hospice, or we start thinking about advanced therapies, mechanical support, transplant, or even inotropic support at home as a form of palliative management. So again, this is the second admission this patient has with us. We've been following him very closely. We've been aggressive with medical therapy as much as we can. What do we do next? This time we decided to try to discharge him with guideline medical therapy after diuresis, but implant a CardioMEMS before he goes home to see if we can follow him closer and try and see if we can react to his changes in numbers in a more aggressive way. So this is actually a picture of the first CardioMEMS that we implanted here at the Cleveland Clinic in Florida. It's a relatively simple procedure. It's just a right heart cath with deployment of the device. So Champion trial was a randomized single blind trial that implanted 550 patients with a CardioMEMS device. 270 were treatment patients, and the treatment group was simply managed based on PA pressures plus the traditional information. And the control group was management based on just traditional information. So basically patient's weight, blood pressure, and maybe blood work. The primary endpoint was rate of hospitalization for heart failure. So the results were very significant reduction in the risk of heart failure hospitalizations at 6 months and for the duration of the study. The average duration was around 18 months. So this is very impressive. It had a relative risk reduction of 36% in heart failure hospitalizations. This is what the device looks like. And with the results of the Champion trial, the FDA approved the use of the CardioMEMS heart failure system to monitor pulmonary artery pressures and heart rate in patients with functional class 3 heart failure and at least one hospital admission during the prior year. So that is the indication to get one of these devices implanted. And as you can see, our patient had that indication. And when you compare the annualized reduction in heart failure hospitalization rates with other strategies that we use and medical therapy from big trials, it is actually comparable with a 33% reduction. So we implant the device here in the hospital, then the patient goes home with a pillow, and all they need to do is lay on the pillow daily, and this information gets wirelessly transmitted to us through a website, and then we review it. If we want to do it daily, we can do it daily. If we want to do 3 times a week, we can do it 3 times a week. We can do it as often as we want. So this patient had a very close follow-up with review of his CardioMEMS numbers. We decided to do it twice a week. And then based on the changes or stability, we changed, the doses of the diuretics. And if we were concerned, we will order blood work. So it was a really, really close follow-up. This is what we see when we review the CardioMEMS data on a patient. We get waveforms and we get actual numbers of a systolic, diastolic, mean PA pressure and heart rate. This is actually like having a swan catheter in the neck implanted in the patient all day. So this is the degree of, numbers that we get and how accurate this is. So with this strategy, we were able to keep the patient at home for 5 months without hospital admissions. But then at 5 months, the CardioMEMS numbers started to worsen with elevation of PA pressures, and then he wasn't responding to increasing diuretics. So he came in back to the hospital with a 10-pound weight gain, again, decompensated, very symptomatic. And we started aggressive diuresis and trying to optimize his medical therapy. We decided to do a transesophageal echo to take a better look at the mitral regurgitation. And as you can see, very severe mitral regurgitation. So now what do we do? At this time, we decided that our next step was to see if we could do a transcatheter mitral valve repair. We decided that the patient was not a surgical candidate due to his very low ejection fraction and his age. He wasn't a candidate for transplant, and Lvad was not an option because he wasn't going to be able to follow up in this country. As you can remember, he lived in another country. So this is the actual procedure. This is after one clip. This is after two clips. This is how it looked during the procedure, and this is the residual gradients across the valve after the two clips. So the procedure was successful. The degree of mitral regurgitation went from 4+ to 1+. And what was more impressive of all is that his left atrial pressure went from 71 to 34. And when I see the changes in those numbers, I can tell that the patient is probably going to feel much, much better after the clip, because that very elevated left atrial pressure is what really gives them all those symptoms. So it's very important to remember that mitral regurgitation, functional mitral regurgitation, is very prevalent in patients with heart failure. Around 40% of patients that have moderate to severe functional MR in patients with left ventricular dysfunction. So very common. And for all of us who treat and see patients with heart failure, we know that when you have one of these patients that have significant mitral regurgitation, these patients become much harder to manage because they're very symptomatic. Even when they're well diuresed and on optimal medical therapy, they continue to be very symptomatic. So we also know that the mortality in patients with left ventricular dysfunction and functional MR is worse. And the more MR these patients have, the worse their survival is. So then comes in the co-op trial, transcatheter mitral valve repair in patients with heart failure. This trial was published in the New England Journal in 2018, and it showed that there was a significant decrease in heart failure hospitalizations in patients that received the clip compared with guideline medical therapy alone. There was also a significant decrease in all-cause mortality between mitral clip plus guideline medical therapy versus just guideline medical therapy. And it showed that this change and this improvement was significant in all subgroups, including patients with ischemic and non-ischemic cardiomyopathy. There was no difference. All patients did better with the mitral clip plus guideline medical therapy. So then there was a little bit of controversy because almost at the same time, 1 month before, there was mitral FR trial that was done in Europe that showed different results. And it was great because the difference between the results in these two trials made us really look into mitral regurgitation with heart failure in a different way and realize that not all mitral regurgitation with heart failure is the same. And the two trials were definitely not the same. So these patients were different. Important to know that in mitral FR, the left ventricle was actually worst. The patients had a larger ventricle, much more dilated, 65 millimeters compared with an average of 53 in the co-op trial. And these patients also had a higher degree of pulmonary hypertension. So the co-op trial were patients with severe MR with concomitant left ventricular dysfunction. But in the mitral FR trial, these patients had left ventricular dysfunction was their main issue, with severe mitral regurgitation and elevated pulmonary artery pressures. So the concept of disproportionately severe MR, so these are patients that have left ventricular dysfunction, but the mitral regurgitation is disproportionate to the severity of left ventricular dysfunction. Those are the patients that are going to benefit from the mitral clip, different from mitral FR trial. So when we start thinking about patients that we want to perform a mitral clip on, this is the first thing that we have to think about and really evaluate the left ventricle. So this patient, after the clips, had a 15-day follow-up. He felt much better. He was functional class 1 to 2. He had lost 35 pounds. His renal function was actually improving, and we had better blood pressure, so we were able to restart beta blocker, ARB, and spironolactone. This is a follow-up at 6 months. And as you can see, the mitral regurgitation is 1+ maybe, and even his left ventricular dysfunction was improving. At 1 year, he continued to do well, tolerating all his medications with no hospitalizations in between. So now that we have all these options, it's important to remember that when we see these patients where we've tried everything, they're not candidates for transplant, transplant or mechanical support. There is now new technology and new devices that we can use to help these patients. In the case of implantable monitoring devices like the CardioMEMS device, it can help us keep the patients at home, decrease readmissions. And in the case of, structural heart procedures like the mitral clip or TAVR, that were patients that before were not candidate for open heart surgery because of the left ventricular dysfunction. Now we can perform these procedures in these patients and really help the prognosis and outcome. So I want to thank you all. Have a good night.
Thank you very much, Viviana. This was wonderful. We will now go to our last but not least of the presentations. And it's my pleasure to introduce my dear colleague here at the Cleveland Clinic in Abu Dhabi, Dr. Fahad As-Sindi, who joined us approximately a year and a half ago after returning from his training in the US and spending some time establishing the first heart failure clinic in Bahrain. He elected to join our program and has been a rising star with us since then. Fahad will take us nicely through the wrap-up of the escalation on heart failure management to ventricular assist devices and practical tips for cardiologists.
Hello, hi, my name is Fahad Al-Sindi. I'll be talking about heart failure management strategies today, but my task is ventricular assist device, practical tips for cardiologists. I have nothing to disclose, and I'd like to start by some clinical questions. With regards to evaluation of that patients, the presence of radial pulse and continuous flow pump is concerning. Arterial line measurement is the gold standard. Automated blood pressure monitoring is reliable to measure blood pressure, and opening Doppler pressures correlates with systolic blood pressure. With regards to LVAD and bleeding, all is true except bleeding complications are uncommon. The cause of GI bleeding is gut hyperperfusion due to pulse pressure and dilation of the submucosal venous plexus, pathophysiology of platelet dysfunction, lysis, and von Willebrand factors, as well as RV dysfunction are believed to be causes of congestion, and then small bowel should be considered an important source of bleeding. With regards to Alvadix infections, all the following is true except HeartMate 2 data showed 35% of patients develop infection. Risk factors include driveline trauma, continuous movement, and dietary malnutrition. Erythema at the driveline site with no purulent discharge may indicate deep-seated infection, and leukocyte scintigraphy and SPECT have been used and are more sensitive in diagnosing driveline and pocket infections. Inadequate decompression of the LV, all of the following are true. Suboptimal pump speed, increased afterload, obstruction of flow, and thrombosis of pump, aortic insufficiency, or all of the above. With regards to LVAD troubleshooting, all the following are true except pump thrombosis manifests as increase 50% of flow, hemolysis parameters with serum LDH greater than 600, elevated hemoglobin, free hemoglobin, and as well as reduced hemoglobin, and pump stoppage can be caused by depletion of battery power and discontinuation of leads. And finally, kink or obstruction of inflow cannula will cause high power and estimated flows. We know that the mortality of heart failure has been one of the highest in cardiovascular disease and in medicine, with a very dismal 5-year survival mortality. We also know that the number of heart failure transplants have been on the rise throughout the world, so as new adult candidates who are eligible for heart transplantation. We do see from the slide that the distribution of age, we see that more younger patients percentage-wise are less compared to our middle age patients who reaches around 50%. When we think about criteria of listing, we know that the criteria of listing would be between 1 and 4. And looking at specific data from the Middle East region, it is estimated that around 200 to 400,000 patients might require mechanical support being eligible given their functional class, which makes it very important to have centers that are able to have advanced heart failure and mechanical support and transplantation. Historically, circulation has been the wonder of a lot of our scientists, but it's not until Dr. Debicki and his team dreamt of, thought of, and finally came up with the first LVAD that jumpstart our journey in mechanical support. We have gone a long way in our device technology, our device shape, and also in biomechanics. Few words about Lvad statistics. This slide shows that our indication from bridge to transplant to gestational therapy has been on the rise since the early 2000 to 2016, but even contemporary data has showed us a shift from the traditional axial to a more centrifugal and the fully magnetically levitated devices, such as the HeartMate 3. Also, as we saw earlier, that the indication for VAD placements have moved towards destination therapy, indicating the greater population of need and qualifying for stage D heart failure. Indication of LVAD for bridge to transplant, as we mentioned, status 1 to 4 listing, having significant NOHA class, and for DT therapy, these are the traditional indications with a VO2 less than 14 and significant functional class determined, as well as reliant on inotropic therapy and balloon pump support. This is an important slide looking at a special mnemonic, which is I need help, allowing our general cardiologists or cardiologists, heart failure cardiologists in the community and in teaching hospitals to recognize when patients become more sicker and when they require to be referred to advanced therapies and advanced heart failure settings. There's a number of contraindications, and some of them are relative and some of them are absolute. And it's important also to have not only physiological stability, but psychological stability in all of these patients who are evaluated in our multidisciplinary meeting. The Intermax clinical profile remains a very important determinant in determining the timing of placement of LVAD. If we place the VAD too early, patients might not require, and we give them the complications of the LVAD that we're going to talk about soon. And if we think about implanting somebody with the Intermax 1 at a time where they're crashing and burning, and that also poses a risk of increased bleeding, coagulopathy, and renal failure, as well as right ventricular failure and poorer outcomes. The VAD physiology is very interesting in those patients with poor forward flow and very elevated filling pressure. In unloading the left ventricle increases cardiac output and reduces filling pressure. Pump flow function is a function of speed, and speed is directly proportional to flow. As we increase the speed, we increase the flow. But the very important difference is also the pressure gradient across the LVAD, with increased pressure gradient causing low flows and decreasing the afterload, decreasing and increased outflows. The right ventricular function is an important determinant and partner. And as a matter of fact, it's RV dysfunction that worries us as advanced heart failure cardiologists. We know that 20% of VAD implants require inotropic and RV mechanical support, and RV pre-implant assessment is a key component of determining eligibility for LVAD. Patients who have primary right ventricular disease are at a high risk, such as Epstein's, ARVD, or chemo induced cardiomyopathy. More objective measures such as RV stroke index, ratio of RA and wedge pressure, and elevated BN are all key determinants in predicting RV failure following LVAD placements. We've gone a long way from our initial XVE pumps, which were big and bulky, and relied on different technologies. And in contemporary continuous flow pumps, looking at the HeartMate 2 and the HeartMate 3 and the HVADs, and looking at even early data from the rematch data, showing survival benefit with patients compared to optimal medical therapy. Continuous flow pumps don't come without complications. We're going to talk about them, but suffice to say that the survival has been pretty well with HeartMate 2 devices, faring better than pulsatile flow devices. And with the HVAD, LVAD has proven non-inferior to the HeartMate 2. An important cohort of patients are the walking and talking patients, and this is data from the roadmap, which are self-declared patients with a low functional capacity. It showed that patients had an improvement in their 6-minute walk. However, the fact that they elected not to go for VAD support, they did not pay the price for it, and the intention to treat analysis showed no major difference in mortality in those patients. But however, percentage severe survival with regards to reoperation and removal was much lower in the HeartMate 3 patients. Clinical evaluation is very important. This is a chest X-ray that we see in the ICU, but when we see our patients, we'd like to take a full history, full exam, ask about anemia, ask about bleeding, and ask about fever, infection, and also ask about alarms and VAD malfunction. Routine labs and workup are essential, but importantly, when we examine patients, measuring their Doppler blood pressure in the office with Doppler gives us the mean arterial pressure, which ideally should be between 60 and 80 millimeters of mercury. Looking at the VAD assessment, we look at different parameters such as speed, power, flow estimation, and pulsatility index, as well as auscultating over the pump for hum and modulation. With regards to compilation, stroke has been a dreaded complication with biphasic incidence highest in the early postoperative period, and then another spike within 9 to 12 months. Risk stratification is very important, both in the pre-patient factor selection with sicker patients, during the operation, aortic loss clamp and cardioplegia, as well as duration of mechanical support, high systolic blood pressure and discharge, and higher or low INR. Odds ratios of uncontrolled blood pressure are significant risk both for ischemic stroke as well as hemorrhagic stroke. And when we talk about hemorrhage, GI bleed has shown to be one of the highest causes of bleeding. Bleeding is a complication that requires transfusion, hospitalization, and reoperation. We also know that from a GI bleeding standpoint, that angiodysplasia is due to mostly gut hypoperfusion because of decrease in pulse pressure. And in patients who have bridge to transplant, it's important to consider leukocyte-depleted blood to reduce the risk of allosensitization. Important to note that these patients do have small bowel bleeding, and a push enteroscopy is an important aspect of their management. Looking at Lvad thrombosis, patients who have low pump speeds, reduced INR, and poorly controlled blood pressure. It manifests by increase of greater than 50% of power with elevated estimated flow. And pathophysiologically, hemolysis does occur with clinically presenting with T-colored urine, elevation in serum LDH, bilirubin, haptoglobin. Infection in LVADs, they can be related to the VAD itself, and they can be specific. And we can see that driveline infection is something that are very important. And stage 1 are simple erythema, reaching to stage 3 with more deep-seated infections that are quite dangerous. RV failure is something to be kept on our mind, looking at poor VAD flows, low cardiac output, and high CVP to RA ratios, as well as patients presenting with hypertension, liver congestion, and right-sided heart failure. Suffice it to say towards the end that VAD survival has been magnificent over the years and is a very variable option that improves quality of life and mortality. And this is the balance we do with mortality and quality of life. VAD management is a multidisciplinary team, including a number of key players. Finally, to the questions. With regards to evaluation of VAD, arterial blood pressure still remains the gold standard, despite in the outpatient clinic, we do the Doppler-based measurement of our mean arterial pressure. And when it comes to LVAD and bleeding complications are common. That is false. It's one of the commonest complications of LVADs. When it comes to LVADs and infections, erythema on the driveline site with no praline discharge does not indicate a deep infection, and it's a superinfection that can be treated topically. And when it comes to inadequate decompression of the left ventricle, we would say that all of the above are causes of inadequate LV decompression. And when it comes to troubleshooting, a kink or obstruction of inflow cannula will cause low power as opposed to higher power in this question. And with that, I thank you very much.
Thank you, Fahad, Viviana, and Bjorn for a wonderful second half of this session. We now have a period of discussion for about 15 minutes. And Randy, did you have any questions for our speakers to kick it off?
Yes, I do. And I want to also remind the audience to please send us your questions, and we will do our best to respond to all of them on the chat. So I want to begin by asking Viviana a question that kind of came up as she was going through her case. So we talked about sequencing of medications. So Viviana made me ask myself about sequencing of the procedures. So CardioMEMS, the MitraClip, and it begs the question, which is the patient should be fully optimized with GDMT and diuretics before a MitraClip, for example, or any other percutaneous device is considered. So I'll ask Viviana to make a few comments about sequencing and how she works through a case. And
yes, no.
just, I don't know about other parts of the world or even Florida, which is of course in the US, but we have a hard time getting CardioMEMS here in Cleveland because of insurance.
Yes, so no, great question, and it's something that we face, I think, with every patient. When we are used to being able to access advanced heart failure, and we come up with these patients that are refractory, and we have to come up with new things to do for them, or a different way of doing them. It's not always easy to, you know, look the patient in a different way. CardioMEMS, we were able to start the program back in 2019, and it's the one device that we use the most. There are other devices. We found it very, very useful in patients that had recurrent hospital admissions. You have to be good about following the patient closely, following their numbers, and reacting to them with changes in medications. So I think the advent of all these new devices to monitor patients at home are going to change the landscape of, you know, the outpatient follow-up of advanced heart failure patients that are not candidates for anything else. We tend to do the CardioMEMS as the first approach in patients like this. And then we've seen multiple cases where the patients come with severe mitral regurgitation that is functional, and after a 20-pound, you know, diuresis, the mitral regurgitation goes from 4+ to 2+. So absolutely, before you do any form of structural, you know, clip, TAVR, anything like that, you have to have an optimized patient medically. I've had patients that have a left bundle, and just by implanting bi-V pacing, the MR also goes down. So in this case, despite aggressive diuresis, the patient continued to have severe mitral regurgitation, and that's why we decided to do the clip. I've seen amazing results with mitral clips.
And before you go, this question just popped up. It says, is CardioMEMS cost effective?
I think it is. I mean, just the fact that it decreases readmissions, I don't know how it is in the rest of the world, but in the United States, we get heavily penalized by heart failure readmissions. Monetary, I mean, the hospital ends up paying a lot of money for every single one of those readmissions. And we try to figure out ways. Obviously, the primary objective is quality of life for the patient to stay home feeling well. But then when you start talking about cost and effectiveness, I think it's worth a device that has this 33% relative risk reduction of hospitalization. I do think it's cost effective.
I would tend to agree with you. Just when you counterbalance the cost of the device versus the cost of a readmission and multiply, you can, I think, quickly decide that it's cost effective. And we will hopefully soon have some mortality data, right?
Yes, exactly. Yeah, that's hopefully gonna be positive. So it's another way of, we're so good at managing these patients in the hospital, but not so good at being able to keep them out of the hospital. Once they leave the hospital, that's when problems start. So this type of devices, I think, are gonna help us change that.
Okay. And thank you, Viviana. And
thank you, Dr. Sally.
The question I had for Bjorn that I think many in our audience will be interested in hearing relates to side effects of SGLT2 inhibitors. So what do we need to tell our patients to look out for, and what might happen as far as the side effect that we would have to stop the SGLT2 inhibitor? Could you comment on that, Bjorn?
Absolutely. Thank you, Dr. Starling. So I counsel all my patients that when I start an SGLT2 inhibitors, that they might run a little bit on the drier side. And I like that all my patients have a weight scale at home, upper extremity blood pressure cuff and a pulse oximeter, and we stay in very close communication with them. And I counsel them, if they feel dizzy or lightheaded, or if the weight gets down, to please contact our office and we will adjust the loop diuretics. I also quite frequently see actually fungal infections, UTI in particular in women. This is a problem. What we usually do is then we pause the SGLT2 inhibitor, treat it, and then at some point we'll re-challenge them again. I mean, it's a mortality and hospitalization reducing drug, so you really have to convince me to withhold this from one of the patients. So these are the two most common things that I see. And I want to also point out that unfortunately now more and more of our type 2 diabetes patients can develop type 1 diabetes with ketoacidosis. It's not the very thin diabetic patient anymore that we saw in the past with onset of type 1 less than 30. So diabetic ketoacidosis for sure is a problem. And I have seen one patient in the ICU where an SGLT2 inhibitor wasn't stopped and unfortunately went in profound ketoacidosis. So that's I want to make sure that that there is no history of diabetic ketoacidosis. But in general, to be honest with you, they are tolerating those in my experience quite well.
Very good. Ferris, it looks like there's some LVAD related questions that are popping up. Maybe you want to direct those questions, Ferris?
Yes. So there is actually a very good question here to Fahad, perhaps, about the role of transthoracic echocardiography in LVAD patients. So Fahad, what do you look for when you do an echo?
I think, in general, echocardiography is extremely important for heart failure, but it's essentially, I think, the fifth vital sign when it comes to evaluating our LVAD patients. Obviously, there's a number of things that are key that, tells us about filling of the LV, function of the RV. So the interventricular septum and whether the septum is shifted to the left or right will tell us hugely whether the LV is underfilled or overfilled, if there are hypovolemic states, if there's any abnormality in the inflow cannula, meaning if there is a malalignment of the inflow cannula. In addition to that, visualization of the aortic valve is also very important. Adequate VAD flow will usually cause the aortic valve to be closed. If VAD flow is actually reduced, or if the rotation is reduced, then you'll see that the aortic valve, intermittently opens. In addition to that, when patients come in with a suction alarm or a hypovolemic state, It's also, besides the patients being hypovolemic or have a GI bleed, other redistributive problems can be also visualized, such as a pericardial effusion or a pending tamponade, as well as overt RV dysfunction in the setting of severe tricuspid regurgitation as well. Another important key is looking at aortic regurgitation, and even looking at the presence of moderate aortic regurgitation is quite significant by color Doppler.
Very good.
There's an initiative on main campus that Dr. Estep put into place. So all of our LVAD patients have a right heart cath and a ramp study for speed adjustment in an effort to reduce readmissions. Fahad, maybe you could briefly tell the audience about a ramp study.
Yeah, I mean, we don't usually do a ramp study actually as far as our protocol, but it has to do with evaluating about the VAD speed and the assessing the opening of the aortic valve, as well as the movement of the septum. The main optimization is to optimize the septum to be in the center, optimizing LVAD speed at that point.
And I'm going to put a difficult question out, but I'm seeing it more and more in the literature, especially as we're learning more about the HeartMate 3. So the question that I get asked is survival as good with a HeartMate 3 LVAD current technology as a heart transplant? How would you answer that question?
Well, so the question is heart transplant versus the HeartMate 3. That's surely a tough one. But I think the Achilles heels of a lot of our mechanical support, durable mechanical support, is risk of stroke and be it thrombosis or bleeding. And this has been, one of the major advances, in my opinion, in the levitated magnetic technology that the HeartMate 3 offers, with reduction in reoperation and reduction in thrombosis, and also being able to be very lenient as far as interruption of anticoagulation or antiplatelets, if needs be, when patients develop bleeding complications such as GI bleed or even simpler bleeding such as epistaxis. I still believe that there's no alternative but transplanted heart, but at least it does gives a lot of our DT patients a very long life to think about as well. And in places, in my opinion, where there is scarcity of donor organs, and we know that there is a variability between North America, Europe, and also in the MENA region, and then HeartMate 3 can be a very reliable mechanical support until a donor heart is available.
Randy, I would say the short-term survival is equally good. The long-term survival is yet to be known between the HeartMate 3 and heart transplant. But you said you get asked this question a lot, so tell us how you answer it.
Yeah, I think I have a bias, and if somebody is a transplant candidate, it's hard to debate the results as far as the next 10 to 20 years outcome. And if that's not an option, I think current LVAD technology provides an excellent option to improve survival and improve quality of life.
Agreed. Well, we're coming to the end of the webinar here. I would like to thank our audience for staying with us late this evening for this heart failure webinar, which kind of concludes the series of webinars from the Cleveland Clinic. And I would like to thank very much our colleagues from Ohio and Florida, in addition to my colleagues here in Cleveland Clinic, Abu Dhabi, and especially my co-moderator, Professor Starling, for their wonderful contributions. I look forward to seeing you all in person at some point soon for more educational activities that combine the different centers of Cleveland Clinic across the globe. Thank you very much and have a wonderful evening.
Thank you.